I think that went pretty well. How we coordinated the session. I really liked the how you went over the some of the current data with regard to safe hormone prescribing and what the pitfalls really are or are not.
Yeah, I mean, I think it's important for clinicians to realize the different options that are available for how they prescribe hormones for transgender patients, the many different testosterone options that are out there, but how they differ in terms of, how they're given and frequency and cost and potential adverse effects and what's been studied versus what's not been studied, and also some of the pitfalls with estrogen and high-dose estrogen and which formulations to avoid, such as the ethinyl estradiol.
And I think it's also just very important to start to really structure this into an evidence base. I think I kind of said that a little in my talk, where I'm thinking about how we educate trainees, and frankly, the model can apply to physicians in practice at this juncture, thinking about our evidence base for gender identity and how that affects our framework and our formula. And also our strategies for care. And then once we get to those strategies, as you were pointing out, what some of the concerns might be with some of the different hormone regimens, and what we do and what we don't know.
Yeah, and I know you mentioned that I think it's a very important thing is getting clinical exposure for those interested in learning more about this. And the didactic is great in learning about all the background, but really having clinicians get in touch with transgender patients and having firsthand experiences.
I think that's just a huge point that I think I hadn't appreciated, as you heard during my talk. I was so self-congratulatory that if we were sufficiently evidence-based that we would appeal appropriately to your typical physician or scientist, and the fact that there's need for an actual direct patient experience, which of course we know that's why the medical training programs in the United States are the best in the world. That's part of that. It's third and fourth year of medical school, it's residency, et cetera, et cetera. So of course it should be true, but the fact that I kind of had to have it pointed out to me by a medical student is I guess just real life, how you can be wrong. I was thinking too, as we were going through, like with regard to the gaps, like I noticed that you referenced the data about transdermal preparations maybe being less risky than oral preparations, but that we still have the gap in terms of understanding why that is.
Yeah, there's so much we don't know just because the data is there's so many fewer transgender women that have been studied than postmenopausal women. So although I think there are gaps, I think it's helpful until we fill in the gaps just to kind of extrapolate some of the knowledge, especially if it makes sense. But it is very interesting because, for example, a lot of the studies in trans women have all looked at oral estradiol, whereas so many trans women are taking it sublingually. And to me, it makes intuitive sense that it would be safer because it's bypassing the liver, so maybe it'll have less of a risk, but we really don't know in the end.
Yeah, I actually like that data a lot. I was thinking to myself kind of the opposite, in fact, because I was thinking, it's possible that first pass is relevant, but it's alternatively more important that the dose response and risks there. And so if those data that you had with regard to the actual greater levels with the people who, of course, took sublingual in a controlled condition, so that they actually took it sublingually, you almost wonder if dose response is where the money is, that wouldn't even be worse for you. But of course, we don't know. Those are more studies to do, right?
And it's so important, I think, for clinicians to always ask their transgender patients what they're taking, because it's very common for us to prescribe an oral estradiol or to write that on the prescription, and then we may not realize that they're actually taking it sublingually, and that may explain like a lab abnormality, for example.
That's an enormous point, in fact, right? And patients might not think that we care on that point, or they might think it's safer because the internet lore, we'll just call it that for the moment, suggests that it's safer because it's very first pass oriented and not very dose response oriented. Okay, very interesting.